of someone who needs me, someone I need.
Can you hear me? Great. So I'd like to welcome you to this evening's satellite symposium entitled Chemotherapy-Induced Nausea and Vomiting, Pathways to Improving Patient Outcomes Using a Guideline-Based Approach. My name is Paul Hesketh, and I'll be serving as the chair for our session this evening. We're very fortunate to have a superb faculty joining us as well, including Stephen Grunberg, who is our newly installed president of MASC. And Steve is also a professor of medicine and pharmacology at the University of Vermont. And Carrie Stricker, who is a clinical assistant professor at the University of Pennsylvania School of Nursing in Philadelphia. And finally, Dr. Richard Gralla, who, as you know, is our symposium chair and is also medical director of Quality of Life Research Associates here in New York. So this program is being jointly sponsored by the New York Medical College and also the University of Nebraska Medical Center College of Nursing. continuing nursing education. And we've been very grateful for the expert assistance of Continuing Education Alliance. We also are very grateful for the financial support being provided through an educational grant from ASI. So the learning objectives are shown here. Hopefully, by the end of our session this evening, we'll have, or you will have, some sense about the impact of nausea and vomiting on patients' quality of life. Hopefully, you'll have some understanding about how how chemotherapy agents can be categorized in terms of their metagenic risk. Also, you'll be seeing data supporting the use of the individual agents and combinations in various settings, such as highly metagenic and moderately metagenic chemotherapy. And then I think most important, having some understanding about the importance of trying to implement guideline-based strategies to try to ensure that our patients have the best outcome when we prescribe antiemetic therapy. So I'm going to start with some introductory comments, and my disclosures are shown here. And we also, I think all of you see a little audience response pad. We are going to, before each speaker gives their presentation, there'll be one or two questions which we'll be asking for responses from the audience. What we will do is show the results at the time that this is done, and then at the end of each talk, we'll show the same questions again, ask you to re-vote, and then try to compare the outcomes between prior to and after this talk. So our first question relates to patient risk factors. A patient-related risk factor for CINV is 1, a history of moderate alcohol use, 2, older age, 3, female gender, and 4, chemotherapy naive status. So if you could just vote for one of those, please.
Once in my life, I have someone who needs me, someone I need.
Okay, so we'll come back to that at the end of my talk, and we'll ask that again. And one other thing that I wanted to mention, just in the way of housekeeping, is that your meeting materials folder has program handouts, including an evaluation survey form. So we really would appreciate it if at some point toward the end of the program you're able to fill out that survey. We also have question cards in there as well. And we're not going to be taking questions at the end of each speaker's presentation, but we will hopefully have time at the end to respond to questions that people write down on the card. So please take those cards out. If you have a question after someone has given a talk, please write it down. People will be coming around to collect those, and we'll try to address those at the end. So I think, again, I'd like to just begin with some introductory remarks. I think we're all aware that chemotherapy-induced nausea and vomiting is a significant problem, that if we don't control it adequately, it's going to result in increased morbidity. It's certainly going to increase the cost of care. And I think most importantly, it's going to impair patients' quality of life. And we know that chemotherapy-induced nausea and vomiting can really present in a number of different patterns. We know that if it occurs within the first 24 hours, we term that as acute nausea and vomiting. If it develops beyond 24 hours, we call that delayed. And it turns out that delayed nausea and vomiting is more of a problem at the present time than acute, occurring approximately twice as frequently as acute nausea and vomiting. And we also know that both the pattern and the incidence of delayed nausea and vomiting is very much dependent on the chemotherapy agent. We also have anticipatory emesis, which is really a conditioned response based upon a bad prior experience, which we can hopefully eliminate by having a very good experience with the first time patients receive chemotherapy. We also have breakthrough emesis, where emesis develops despite the use of prophylactic medications. And finally, we have refractory, where emesis develops despite the use of prophylaxis, despite breakthrough medications, and yet the patients are still having a nausea and vomiting. So there are a number of factors that can predict the likelihood of emesis, some related to the patient, some related to the treatment itself. We know that factors that increase the risk of nausea and vomiting include younger age, female gender, emesis with prior chemotherapy, either low or absent alcohol use, and even certain polymorphisms in the metabolic pathways for antiemetics and in the neurotransmitter receptors themselves. There also obviously are treatment-related factors, and clearly the most important factor of all these is the intrinsic emetogenicity of the chemotherapy. So just a couple of quick words about the physiology of nausea and vomiting. I think it's important to realize that nausea and vomiting really, over time, have really evolved as important defense mechanisms that allow an animal to protect themselves from ingested toxins. And given the fact that this has occurred over such a long period of time and has an important protective effect, there's really a lot of redundancy in the system. There's a lot of plasticity, and that can make it much more difficult to eliminate emesis because you have other ways to get around. If you block one pathway, you can go around another pathway and still have an emetic response. Some of the components that we know about in terms of CINV include structures within the central nervous system and clearly structures within the gastrointestinal tract. The CNS structures that are important include anatomically indistinct center known as the emetic center, or the emetic central pattern generator located in the medulla. And this is the final efferent pathway through which stimuli come and are processed and result in the emetic reflex. We also know that we have an area postrema located in the floor of the fourth ventricle that is an area that is able to take stimuli from blood and from the cerebrospinal fluid and potentially stimulate emesis in that fashion. And even the higher cortical systems are involved, particularly in the limbic system. The gastrointestinal tract is critically important, and the enterochromaffin cells in the wall of the small bowel contain a number of neuroactive peptides, particularly serotonin or 5-hydroxytryptamine, and the visceral afferents that project to the brainstem are obviously critically important as well. This particular slide just shows a cartoon that attempts to depict where chemotherapy may be exerting its effect in terms of inducing nausea and vomiting. It clearly has an effect on the small bowel in terms of the enterochromaffin cells, causing the release again of those neuroactive peptides, particularly serotonin, which can then bind to the adjacent receptors on the afferent nerve fibers going from the vagus and the splanchnic up to those areas within the central nervous system that are involved in the emetic reflex arc, the area postrema and the emetic center. We also know that chemotherapy may, either directly or more likely through metabolites, have an ability to interact directly with that area postrema. And then there's a sense that chemotherapy may also interface with higher centers, such as the limbic system, to also contribute to the emetic reflex. So we know that there are a number of neurotransmitters that are important in emesis in general. This is a list of some of those. And with respect to CINV, the ones that seem to have assumed the greatest importance historically are shown here: dopamine, cannabinoids, and particularly in recent years, the focus of drug development has primarily focused on serotonin, or 5-hydroxytryptamine receptor antagonists, and neurokinin-1 receptor antagonists. So shown here is just a quick review of some of the key milestones. And again, I'm not going to go through all of these, but again, we're talking about a 50-year period of time, starting with the introduction of phenothiazines 50 years ago as really our only effective or modestly effective antiemetics, and moving on to the neurokinin-1 receptor antagonists, which were introduced about a decade ago. So a lot of progress, but clearly we will only be happy when we get to the point where we have completely eliminated nausea and vomiting for all of our patients, and that's ultimately our goal. And hopefully we will show that this is best done with our current approaches by implementing evidence-based preventive treatment. So let's come back to that first question again, and I would ask you to, again, answer this question. Patient-related risk factor for CINV is number 1, a history of moderate alcohol use, 2, older age, 3, female gender, and 4, chemotherapy-naive status. If this works properly, we will be able to see the results here. So I should put my glasses on so I can see this. I'm not sure I'm going to be able to see it even with my glasses on. So, all right. Well, it looks like we actually, I think the orange is post. Is that correct? Okay. So we basically, I think we've done a good job because female gender is in fact the identified risk factor, and we've been able to educate some additional members of our audience. So hopefully we'll make similar progress with our other speakers. So at this point, I'd like to introduce our next speaker, who is our current MASS president, Steve Grunberg, who's going to be giving us an overview on the pharmacology of antiemetic agents. Steve?
Well, as has been pointed out, to understand a problem, to take care of the problem, to treat it, you must understand the problem itself. For nausea and vomiting, this has meant understanding both the physiology of the problem, as Paul has discussed, and the pharmacology. And the pharmacology has been a matter of identifying specific pathways, specific neurotransmitter receptors that can be effectively blocked to break the emetic reflex arc without leading to unacceptable toxicities or unacceptable side effects. So what we're going to do is to go over a bit of the history that has gotten us to this point and the various pathways that we have considered. These are my disclosures, and again, very similar. I think those of us in the faculty have worked in the development of many of the agents we use today. Here are the questions. Again, we'll have a couple questions this time. So the first is, the neurokinin-1 receptor antagonists block binding of substance P, serotonin, dopamine, or corticosteroids. And I would ask you to answer these questions. Okay, and we seem to have most people agreeing on what the answer would be. The next question, the 5-HT3 receptor antagonist with a half-life of about 40 hours is granisetron, dolasetron, palonositron, or ondansetron. And once again, I would ask you to answer this question. And you folks are very, very quick. So, okay. Thank you. I don't understand that either. As a third question, administration of aprepitant has a significant effect on the metabolism of all the following drugs or drug classes except steroids, oral contraceptives, cyclophosphamide, or 5-HT3 receptor antagonists. And let's see if we can do this one so that people actually get to vote.
Doctor, doctor, give me the news. I got a bad case of loving you.
Okay, and we have a bit more of a controversy here, which gives us good reason to move forward with the lecture. In terms of the agents, the older antiemetic agents, like I say, we always like to think as scientists that we're logical, and a lot of what we're talking about is we know which pathways are important, we know which ones need to be blocked, and therefore we can move ahead. Corticosteroids, of course, are the class that breaks the rule. We know that corticosteroids are effective as antiemetics. We don't know how they work. There have been a dozen different theories. We're really not sure. The mechanism of action is still uncertain. It may involve prostaglandin synthesis. It may involve vascular permeability. It is not strictly a potentiation effect. Again, although corticosteroids do potentiate other antiemetics, corticosteroids do have a certain amount of efficacy, even as single agents. And again, that's efficacy in both the acute and delayed periods. So there is something very basic, or possibly several things very basic, that corticosteroids are doing that contribute to antiemetic control. Dopamine antagonists were actually our first major family of antiemetics. And again, on Dr. Hetzke's slide that began with work done in the 1960s, it was indeed dopamine antagonists, in that case the phenothiazines at standard doses, which were our earliest antiemetics, beginning with prochlorperazine and then working over the next 20 years to metoclopramide and high-dose metoclopramide. There is dopamine receptor blockade in the area postrema, which particularly at the chemoreceptor trigger zone, and also decreased sensitivity of vagal afferent nerves, so that the dopamine receptors do indeed have effects on both the peripheral and central pathways of emetogenicity, which makes them very widespread, which made them very effective agents in the early going. The problem, of course, is the therapeutic index. If you are going to use very high-dose phenothiazines or very high-dose anti-dopaminergic agents, To get good antiemetic protection, you are also going to learn a great deal about antidopaminergic toxicities. You will learn all about Parkinsonism. You will learn all about ocular gyrate crisis, torticollis, as well as the more subtle anxiety and depressive reactions that these agents can indeed cause, and which can also be very difficult to manage. The cannabinoids are sort of one of our old new agents. They are agents that have actually been around for a very long time and have even been approved as antiemetics for a very long time, but have not been widely used. Interestingly enough, where almost every other category of antiemetics works by being a receptor or pathway antagonist, the cannabinoids work by being a cannabinoid pathway agonist. And again, you can see an agonist antiemetic effect on the enterochromaffin cells. There also are some anticholinergic effects. Low therapeutic index has always been the complaint about the cannabinoids, that if you run the dose too high, you're going to get the psychotropic effects and other unpleasant effects that one thinks of when one thinks of cannabinoids. However, some newer work has suggested that this may actually only be true for anti-vomiting effects, and for anti-nausea effects, we actually may be able to get efficacy with lower doses and avoid some of these side effects. And there will be work on this particular area presented, I believe, in the poster sessions tomorrow. These are the 5-HT3, the serotonin receptor, serotonin, and there's serotonin receptor antagonists. And as you can see, there is quite a similarity in the basic structure for all of the so-called first-generation 5-HT3 receptor antagonists with serotonin itself. The second-generation agent, palonosetron, has a bit of a different structure. It has a third ring in the basic structure. And this may actually be related to some of the differences in the properties of palonosetron from some of the other agents. All of them will indeed block serotonin receptors, 5-HT3 receptors, but there are some differences that we are still attempting to understand. This is looking at the 5-HT3 receptor and the 5-HT3 receptor pathway. This is indeed a calcium channel, and as you can see, having serotonin bind to this calcium channel does indeed open the channel, while having a 5-HT3 receptor antagonist bind blocks this effect and closes down the channel. So this is the basic effect of serotonin and a 5-HT3, and a serotonin receptor antagonist. There are similarities as well as differences to the different 5-HT3 receptor antagonists. Looking at the half-life, most of them, at least the first generation ones, seem to have a 7 to 10 hour half-life. The half-life for palonosetron, the second generation drug, is quite a bit longer. It's 40 hours, which led people to wonder when the drug first came out whether there might be a more extended effect or even an acute delayed effect, simply because the drug remains in the system at measurable levels for a long time. I would remind you, of course, that what we're talking about there is how long a serum level is maintained, which still is a pharmacokinetic parameter, not a pharmacodynamic parameter, and does not really tell us how long the drug might stay on the receptor itself. Binding affinity, again, gives you more of a hint toward the pharmacodynamics. And once again, there is a difference with palonosetron having a binding constant that is several points or several logs higher than the binding affinity of the first-generation 5-HT3 antagonists. So again, some properties that made one think that the drug might act differently if these were indeed the key properties. Now, some of the clinical studies comparing these agents did indeed show some difference in their efficacy. The palonosetron in head-to-head comparisons done against dolasetron and against ondansetron did indeed have better efficacy in the acute and delayed period, most noticeable on days 2 and 3. Now, not perfect protection, but maybe 5 percentage points, but enough to be a notable separation of the complete response curves for these different agents. However, this could not be accounted for by either the longer half-life or the binding affinity to the receptor. If it was merely the longer half-life, then repeated doses of any 5-HT3 antagonist should have given the same results. But it has really not been possible to completely reproduce the efficacy of palonosetron merely by giving repeated doses of a 5-HT3 antagonist with a shorter half-life. And therefore, the longer half-life cannot really account for the increased efficacy. We therefore started looking for, actually, I should say, Slusher, Rojas, and colleagues have done much of this basic work trying to look for biochemical differences and pharmacologic differences between palinositron and the other 5-HT3 antagonists. One thing they have suggested is that in addition to the serotonin binding site that is common to all of the 5-HT3 antagonists, that there might be a second binding site on the 5-HT3 receptor that palinositron binds to that allosterically alters the receptor and that might lead to, in essence, a different sort of binding or a more persistent sort of binding. Another difference is the disposition of the bound 5-HT3 receptor. 5-HT3 receptor antagonist. In this particular experiment, they treated cells with different 5-HT3 antagonists and then did an acid wash. If the 5-HT3 receptor antagonist had bound to the 5-HT3 receptor on the surface, then the acid wash should have completely removed the 5-HT3 receptor antagonist. And as you can see, in the case of the ondansetron and the granisetron, there was indeed very little, only 2 or 3%, of the measurable drug left after the acid wash. With palinositron, after the acid wash, more than 50% was still detectable in the cellular fraction, suggesting that the palinositron had been protected from the acid wash. This and experiments that followed have suggested that a palinositron 5-HT3 receptor complex may be internalized within the cell, accounting not only for the longer effect, but for a different sort of effect. These are not definitive studies, but they're highly suggestive that there is something different about the way this compound is handled by the cell that may have clinical implications. Moving on from serotonin to substance P and the NK1 receptor, once again, substance P is an 11 amino acid tachykinin. It has numerous different biologic activities. It binds to the NK1 receptor. I'm not going to go through the whole list of biologic activities, although I will mention that plasma protein extravasation, depression, as well as emesis have all been, as well as and pain control and control of itching, have all been related to the substance P NK1 pathway. The NK1 receptor is indeed a membrane-bound protein, as most of these are. And again, the complex, now activation or blockage of this complex now has an effect both on acute and delayed emesis, but appears to have more of an effect on the pathways that control delayed emesis, as opposed to the serotonin pathways and the dopamine pathways, which again have effects probably in both the acute and delayed period, but more of an effect on acute emesis. This is an interesting study. Not quite sure what to make of it. There were similar studies that were done previously with serotonin, but this study looked at substance P levels after administration of chemotherapy. And what they found, again, if you look at the left versus the right, is that the patients who had emesis, if you measured the substance P levels in the serum, actually had higher levels of substance P than those who had no emesis. And again, work done by Gebedo and colleagues many years ago showed similar things for serotonin, that indeed there could be a spike in the levels after administration of chemotherapy. Perhaps this does imply a mass effect that would have more of an ability to overcome blockade. Again, interesting data that may give us some insight into how these agents work. Aprepitant is, actually the aprepitant family, aprepitant and fosaprepitant, is the only NK1 antagonist approved for clinical use in humans in the United States. They have little or no affinity for the other receptors and a half-life of 9 to 13 hours. Again, whether the half-life is the reason for the effect on delayed emesis, whether it's the duration of the binding of these agents to the receptor, which of course could last well beyond the detectable serum levels, or whether it's merely a matter of prevention by treating with these agents early before the pathways have been activated that are going to cause delayed emesis, that indeed itself might be the mechanism of efficacy of these agents. This is an interesting slide. This was an interesting study because we tend to think of these pathways individually. We're dealing with the dopamine pathway. We're dealing with the serotonin pathway. We're dealing with the substance P pathway. And yet there is crosstalk. There is interaction on a neural basis between these different pathways and between the different neurons. This has been particularly noticeable for the 5-HT3 and the NK1 pathways. And here you can see, particularly for the palinositron, that again, in this particular study, they gave cisplatin And then they looked at the effects on these various pathways. And as you can see, although the stimulus, substance P, and the activity, the binding, should have been completely due to the NK1 pathway, administration of palonosetron actually was able to change the efficacy, to change the effects on that pathway, suggesting an interaction between either between these modulators or more likely between the neural pathways themselves. Aprepitant does have a certain potential for drug-drug interactions, particularly on the CYP3A4 pathway, and these can be highly variable since aprepitant is an inducer, an inhibitor, and a substrate for CYP3A4. This has been suggested to affect a number of different agents, although I would have to say this effect on the cytotoxic agents has really not had a major clinical effect in most cases. Cyclophosphamide is metabolized through CYP3A4 pathways. There is a change in both active metabolites and the toxic metabolites. Clinically, it has been difficult to detect any difference in cyclophosphamide efficacy or clinical toxicity. With ifosfamide, there has been a suggestion that there might be a clinically significant interaction with encephalopathy. But again, this is very early and very incomplete data. And again, with other cytotoxic drugs, again, although there are other cytotoxic drugs that are metabolized through the CYP3A4 pathway, we have not seen really major clinical effects. On other drugs, there's more of an effect, and these we do take into consideration. This metabolism of corticosteroids is slowed by the administration of aprepitant, by these CYP3A4 blockers, and for that reason, you do see, clinically, we have come into the habit of decreasing the dose of corticosteroid, of dexamethasone, when we're giving these agents, where one would give perhaps a 20 milligram dose, one gives a 12 milligram dose. If one would have given 8 milligrams BI twice a day, one would give 8 milligrams once a day. Oral contraceptives can also be affected. The metabolism can be increased by activation of the CYP3A4 pathway. None of us have ever wanted to see if this is a clinically significant effect in patients receiving chemotherapy, but we do recommend that alternate methods of birth control be used. Effects on 5-HT3RAs have really not been a problem. In terms of warfarin, again, aprepitant, the CYP3A4 induction, will decrease the efficacy of warfarin by about 15%. Now, depending how severely your patient is anticoagulated, 15% less may still be anticoagulated. Again, clinically, it may not be a problem if your INR were to go, for example, from 2.8 to 2.5. However, it is certainly suggested that INR should be checked more frequently in a patient starting an agent such as aprepitant to make sure that the anticoagulation stays within the therapeutic range. There are, in addition, a number of other NK1 receptor antagonists that are in development or have been in development. Casabitant was in development through phase 3, is not being presently developed. Nitupitant, rolapitant, mirapitant, and several others. And again, later this week, there will be other sessions and other talks dealing specifically with the NK1 antagonists that will contain more information about these agents. So, this is the pharmacology that we are dealing with. And now the time has come to see if anybody has been listening. So, once again, if you could answer this question, the NK1 receptor antagonists block binding of substance P, serotonin, dopamine, or the corticosteroids.
All you gotta do is repeat after me. A, B, C, E, F, 1, 2, 3.
Okay, and can we see the comparison? Well, you folks did great the first time and even better the second. Yes, indeed, NK1 receptors are related to substance P. The 5-HT3 receptor antagonist with the longest half-life, 40 hours, is. And again, we'll see if you can improve on your almost perfection of last time.
Competition.
This time you'll get the answer. And very good, it is indeed palonosetron. And we see that the numbers again are very high. And the third question, and this was the one where there was the most disagreement, administration of aprepitant has a significant effect on the metabolism of the following drugs or drug classes except steroids, contraceptives, cyclophosphamide, or 5-HT3 receptor antagonists.
Shake it up. Shake it up.
And Yes, and again, as you can see, it is the 5-HT3 receptor antagonists that are not affected. There is indeed an increase in the metabolism of the corticosteroids, the anticoagulants, and again, a change in the metabolism of cyclophosphamide, as we said. Not clinically significant, but a change all the same. So, thank you very much for your attention, and it is now my pleasure to turn the podium. Thank you. It is my pleasure to turn the podium over to Dr. Carrie Stricker, who will talk on an update on antiemetic guidelines.
Good evening. I'm so pleased to be here in the company of my esteemed colleagues, whose names are scattered all over my slides to follow. And I'll make reference to Dr. Grala's talk from earlier in the day. This update on antiemetic guidelines really is an update focusing on the last few years rather than the last 3 decades, which he had the onerous task of doing earlier today and did such a phenomenal job. And of course, to salvage my own ego, I have to say that there is another reason why I wouldn't be one of the 20 in the room that could do a good job of a 30-year update. So with that, I will proceed forward and give you an update of the past few years on antiemetic guidelines. Okay, nothing to disclose today. And you get to do some voting again. So your first question is anthracycline cyclophosphamide chemotherapy, AC, compared with cisplatin-based chemotherapy is associated with A, lower CINV rates, 2, higher CINV rates, or 3, similar CINV rates. You can vote. We asked them to play the music to make sure you are still awake at this time of the day after the long day. Okay, so we have some variability in responses here, and we will revisit this. Antiemetic guidelines from MASC, NCCN, and ASCO are consistent with and recommended palonosetron as the preferred serotonin receptor antagonist when used as part of which of the following? Dual therapy with dexamethasone for patients receiving MEC or moderately emetogenic chemotherapy, triple therapy with fosaprepitant or aprepitant and dex for patients receiving highly emetogenic chemotherapy, single therapy for patients receiving MEC, so palonosetron alone and moderate, dual therapy with fosaprepitant for patients receiving highly emetogenic chemotherapy. A rather complex question. Let's see how you all do.
I'm hot-blooded, I'm hot-blooded.
Okay, again, we have some variability here. So again, a reason to move forward with the talk. So we shall. So of course, this is just a partial list of the antiemetic guidelines that are available to use for application to practice. And you heard Dr. Grala, if you were in a session earlier today, talk about there being some variability in the guidelines. And of course, we'll focus mostly on MASC because MASC does strive to be the best. And we have National Comprehensive Cancer Network, NCCN, American Society of Clinical Oncology, and then MASC and ESMO joined together. So the antiemetic guidelines are based on 2 main factors, as you're, I'm sure, well aware by this point. The primary factor is the emetogenicity of the chemotherapy itself. Is it highly, moderately, low, or minimal in terms of its emetogenicity? And the pattern of chemotherapy-induced nausea and vomiting, acute, delayed, et cetera. They don't provide separate pathways based on the risk factors that you have already heard discussed by Dr. Hesketh, and that I'll go over here briefly again: female, gender, younger age, history of nausea in a variety of domains. But these are certainly things that we can consider clinically when applying the guidelines to individual patients. So this is, I'm sure, not new news to you either. High emetogenic agents, highly emetogenic agents are those that if prophylactic therapy were not given, you would see 90% or more of patients vomit. The moderate category is a wide-ranging category, 30 to 90%. So there is a lot of variability within this category, which is really important to consider when making clinical decisions on individual patients. And low is 10 to 30, or minimal is less than 10. You've all probably seen some variation of this slide before, which categorizes the agents into these 4 categories. I like to always highlight a few key things. I think dacarbazine often gets forgotten in regimens like ABV chemotherapy as being a highly emetic. And then just again to highlight that in that moderate, there is a whole slew of agents, and certainly ones like Cytoxan, carboplatin are towards the higher end, and there are others that are more towards the lower end. And then you have a number, like the taxanes, etoposide, who are low, and bleo and the vinca alkaloids, minimal. So the 3 recent updates, since I don't have 3 decades to cover, that we chose to highlight today are the updates across guidelines, not all 3, but officially classifying in 2 of the 3 guidelines AC as highly emetogenic chemotherapy, and those are ASCO and NCCN. We'll also talk about changes to the guidelines in the placement of palonosetron in moderately, well, within the guidelines, predominantly in moderately emetogenic. And then we'll talk about incorporation of single-dose IV fosprepitant into the guidelines. So of course, these are the MASC and ESMO guidelines we're showing here, and we'll look at highly emetic as well as AC in this first part of the talk. So while MASC does not officially classify AC, doxorubicin or epirubicin plus cyclophosphamide chemotherapy as highly emetogenic, it gives it its own category for recommendations that's very similar to highly emetogenic. So highly emetogenic and AC in the acute setting get what we call triple therapy, so a 5-HT3 antagonist, dexamethasone, and a prepitant. That's in the acute setting. And then in the delayed setting for highly emetogenic, MASC recommends the combination of dex and a prepitant, whereas for AC, a prepitant alone is recommended in the MASC guidelines. We'll be revisiting this. If you look across all 3 guidelines, I wanted to pull out the differences here in the 3 guidelines in terms of how they manage AC. They're very similar, but there are some critical differences. Given that NCCN and ASCO both classify AC as highly emetogenic chemotherapy, their recommendations for prophylaxis are consistent with that class, and we'll get into that in a moment. And again, MASC, although it doesn't officially classify, has a very similar recommendation, which we already went over. Now, why this move to classify AC chemotherapy in particular as highly emetogenic chemotherapy? What data support this? So one major rationale, and this is quoted in the ASCO guidelines, is that data from placebo-controlled studies indicate that this particular combination, doxo or epirubicin and cyclophosphamide, causes vomiting in 85%, so almost to that 90% level that we have the cutoff for highly emetogenic. Further, if you look at these data from Dr. Hesketh and colleagues and from David Warr's study of a prepitant in the AC setting, what you will see here, if you look at the green bar, that's patients with AC, and the yellow bar is patients receiving cisplatin. And these are data taken from the standard therapy arms, which were very similar. It was a 5-HT3 and dex in the acute setting, and either dex or ondansetron in the delayed setting. You can see here that the complete response and control of emesis rates were actually very similar in the AC versus the cisplatin arm. And in fact, although certainly comparing studies that weren't done at the same time is fraught with peril, you can even see that the AC arm did less well than the cisplatin arm in terms of overall complete response. I'd also like to pull out one further point from this slide, because we're going to focus our time here on AC for the moment. Notice that the overall, so that's the 0 to 120-hour period, complete response, so that means no vomiting and no rescue therapy, was only 40% in this previously standard therapy arm of a 5-HT3 and ondansetron, followed by, in this case, ondansetron in the delayed setting. So can we do better than that 40% complete response rate? So just briefly, because many of you have seen these data before, I'm quite sure, David Warr's study of adding aprepitant in the acute setting to standard therapy with ondansetron and dex, and then in the delayed setting, giving aprepitant instead of ondansetron in the delayed setting. This was done in patients receiving AC chemotherapy. And so what you see here is that there was a gain in complete response rates in this study. So you get up to an overall complete response rate of approximately 51% with the addition of aprepitant here. And the no emesis rate overall in the aprepitant group was 76%, so 3/4 of patients. We still have a lot of room to improve here. 50% complete response rates still leave a lot of room to grow. Dr. Hesketh did a small pilot study looking at can we do better by not only adding dex, because remember in the War study it was aprepitant alone in the delayed setting, no dex given with it. Can we add, by adding dex in the delayed setting and by also giving palonosetron, which has shown superiority in other trials, can we get better response rates? And indeed in this sample of 36 patients receiving AC for the first time, we did much better in terms of no emesis rates. But if you look down below, still 50% complete response rates. So we really need better agents and more work done to help with the nausea piece of the CI&V equation if we want to improve the bottom line of complete response. So let's move now into how ASCO and NCCN have positioned their guidelines and recommendations with respect to prophylaxis of emesis for AC and other highly emetogenic chemotherapy. So it looks the same. So their recommendations for a patient receiving cisplatin and a patient receiving AC are the same, and that is that they indeed get the same triple therapy on day 1, but they recommend dex and aprepitant on days 2 and 3, and then dex alone on day 4. And what's Dr. Hesketh's study was only published in 2012 and was a small pilot trial. Really, this is more extrapolation from the 2 large studies that looked at for AC, I should say it's extrapolation, from the 2 large studies that looked at this exact regimen in highly emetogenic chemotherapy, mostly cisplatin, and showed overall complete response rates of around 70 to 75%. So that's where that recommendation comes from. So we'll move out of HEC, highly emetogenic chemotherapy and AC, and now move into moderately emetogenic chemotherapies. It says other than AC here, because remember, MASC does not classify AC as moderately emetogenic. And so MASC's recommendation is for palonosetron. This was a change in 2010. This was not previously the recommendation. Palonosetron and dexamethasone in the acute setting for acute emesis prevention in moderately emetogenic. And also, sorry, I went ahead and I should have gone back. No, I went back and I should have gone ahead. Okay. So palo and dex, basically palo on day 1 and dex for a total of 3 days, days 1, 2, 3. So if you look across the 3 guidelines, and I'm actually going to broaden out again beyond MEC and just let's consider palonosetron as an agent for a moment. The NCCN, MASC, and ASCO guidelines have some differences in terms of how they recommend the use of palonosetron. The one place where they do all have concordance is the recommendation for palonosetron plus dexamethasone in MEC, non-AC MEC chemotherapy. However, NCCN is the only guideline that actually still states a preference for palonosetron in highly emetogenic, even when aprepitant is employed. MASC does not incorporate that recommendation, nor does ASCO, given the lack of clinical trials that have specifically examined that question. Is palo still superior when an NK1, in this case aprepitant or fosaprepitant, is added to the mix? ASCO does state if triple therapy is used in moderately emetogenic chemotherapy, that then any of the 5-HT3s would be appropriate. So if you have a patient receiving moderately emetogenic chemotherapy and decide to use aprepitant because of their risk factor profile, prior failure, et cetera, you would then have the option of using any 5-HT3, not just necessarily palonosetron. So to give you some background, a quick run through the background of gosh, now I guess it's almost a decade of research, of published research on palonosetron in MEK chemotherapy. This study is Dr. Gala's study of IV palonosetron single dose without any corticosteroids in patients receiving moderately emetogenic chemotherapies, a variety of these. They were randomized to the 3 arms, 2 different doses of palonosetron, 0.25, 0.75, versus a single dose of IV 32 milligrams ondansetron. And you can see from this slide here, if you look at the final bar on the right, that's the overall period, you can see that palonosetron in both doses was superior to the single dose of ondansetron in controlling CINV and achieved rates of complete response. Is this the complete response? Complete response rates overall of close to 70%. And there's a second trial by Eisenberg and colleagues comparing to a different 5-HT3 receptor antagonist, elacestrant, and again in the overall period you saw less robust rates of control with these single doses of 5-HT3s, but you did again see superiority of the palonosetron over the other. And in both, I failed to call it out on the earlier slide, in both that improvement in control rates and complete response rates was really accounted for by the control in the delayed setting. You had some superiority in the acute in the first, but in both trials in the delayed. So the question remained then, so this was not, by the time these data came out, standard therapy was inclusion of dexamethasone in these trials. Only in the second trial were any patients receiving corticosteroids, and even in that trial, the Eisenberg trial, only 5% of patients received corticosteroids. So single doses of 5-HT3s were not standard therapy, so we really needed a trial looking at combination of palonosetron along with dexamethasone compared to a first generation, or compared to the other 5-HT3 antagonists. And so the CYTO trial did just that in both AC patients and other HEC patients, predominantly cisplatinum patients. And so day 1, IV palo versus IV granisetron in this case. Notice the dose of palo is not the approved dose in the US, 0.75. 0.25 is what's approved in the US. And then on days 1, 2, and 3, in both arms, patients got dexamethasone. So this trial incorporated the corticosteroid. And you can see here the primary endpoints. Here were the first 2, the complete response in the acute period and in the delayed period. There was not a difference in the acute, but again, in the delayed there was. And this did translate into a improved control rate in the overall time period as well. So you're getting about, again, you're seeing this 50% number come up again, a 50% complete response rate over the 120. What I think is interesting here also is the no nausea, which you can't see all that well. No, you can. It's just above the no emesis. That you did see improvement in the no nausea rate. So that's encouraging. So the benefit of palonosetron versus granisetron in the highly emetogenic setting, in addition to those older data showing single agent palonosetron in the MEK setting, those 2 bodies of research combined led ASCO to extrapolate use of palonosetron, ASCO and others, to extrapolate use of palonosetron with corticosteroids, given the CYTO trial, to the moderately emetogenic setting. And what about the role of aprepitant? So we haven't talked about aprepitant in non-AC MEK yet. So let's talk about that briefly. So Rappaport and colleagues did a study that looked at CINV in patients receiving both AC and non-AC moderately emetogenic chemotherapy, a total of about 850 patients, randomized using the same regimen as the WAR study did, so basically triple therapy on day 1 with aprepitant. In this case, the 5-HT3 was ondansetron and dex, compared to double therapy on day 1, ondansetron and dex, and then ondansetron in the delayed versus aprepitant in the delayed. And if a post hoc analysis of, since we've already talked about AC data, of non-AC based MEC patients showed the following. So remember, of course, this is a post hoc analysis. So the study was not powered to detect these differences in the subpopulation. What you do see here is that there was an improvement with the addition of aprepitant in the non-AC MEC population in the rates of no emesis. And you saw rates here of very, very good rates of 80 to the high 90%, depending on what time period you looked at. But you didn't see a statistically significant difference, although there was a suggestion of improvement in the complete response rates. So how do the guidelines take all of this and apply it? Aprepitant or fosaprepitant, the IV formulation, basically we have a good deal of variability here. So NCCN recommends that on day 1, oral aprepitant or IV fosaprepitant be considered as an option in certain non-AC MEC patients, and that if oral is given on day 1, you would give it on days 2 and 3. If IV is given on day 1, you would give it just once at the dose. Actually, that's their guidelines at present state 115 followed by the 2-day which is outdated data. We'll go to that in a minute. MASC does not incorporate aprepitant into the recommendations for MEC, and ASCO notes that there is limited evidence here for non-AC MEC, and notes that should, again, as we heard earlier, should clinicians opt to use aprepitant in this population, there's not the need to necessarily use palonosetron, that any 5-HT3 would be indicated. So we're going to close with data on single-dose fosaprepitant IV. And I don't know if this is approved in how many other countries beyond the US. But in the US, it's had its approval for some time now. And the NCCN guidelines incorporate its use in patients receiving HEC chemotherapy or in those MEC patients who would get aprepitant. You can give 150 milligrams IV times 1 instead of a 3-day oral regimen. MASC doesn't include it simply because the last update was in 2010. These data by Dr. Grunberg were published in 2011. And ASCO says for patients receiving HEC who get aprepitant, that IV fosaprepitant is an appropriate NK1 receptor antagonist choice. This is the study. This was a comparison of single-dose IV, Dr. Grunberg's study of IV fosaprepitant 150 versus 3 days of oral. You can see that all patients received the same therapy beyond the differences in the NK1. So they received dexamethasone times 4 days, and they received a 5-HT3 antagonist on dansetron on day 1. And what you see here is equivalency in the primary endpoint of complete response rates over a 5-day period, and an exploratory endpoint of similar no nausea rates as well. So in conclusion, triple therapy as CINV prophylaxis is indicated for patients receiving AC, NK1 should be used. Palonosetron is superior over first-generation 5-HT3s in combination with Dex, and is now, therefore, the recommended doublet in the MEC setting. There is non-inferiority between fosaprepitant times 1 versus a 3-day aprepitant. Yet we still have some outstanding issues of selection of the agent when used as part of the 5-HT3 when used as part of triple therapy, and determining which patients receiving MEC should get aprepitant. So let's go through these final questions and see if I've done my job. So AC chemo compared with cisplatinum is associated with 1, lower CINV, 2, higher, or 3, similar. Go ahead and vote.
Man, there ain't nothing like twisting the night away. There, twisting.
Excellent. So we went from a correct response rate of similar CINV rates of half to 80% here. So good job. Antiemetic guidelines from MASC, NCCN, and ASCO are consistent in recommending palo as the preferred 5-HT3 when used as part of dual therapy with Dex for MEC patients, triple therapy with fosaprepitant or aprepitant and Dex for patients on HEC, single therapy for patients with HEC, or dual therapy with fosaprepitant for patients receiving HEC. Vote. Okay. Excellent. So I'm having a hard time seeing as well, Dr. Hesketh. So triple therapy with, no, I can't see. Dual therapy with DEX for patients receiving HEC. The first one is the correct answer, and we doubled our correct answer response rate here. We still, I offer this opportunity to drive this point home, though, that dual therapy with DEX in patients receiving HEC is the guideline recommended placement of palonosetron. And I would like to welcome Dr. Gralla back to the stage at this point. Thank you very much.
Thank you very much, Dr. Stricker. What a pleasure to join this panel and to follow my good friend, Carrie Stricker. So I was asked to address a few other issues related to guidelines, and let's go through some of these and see how they look to us. But first, and there's my disclosure for this year. And we have these questions to answer, and unfortunately, I'm not allowed to answer here. So adherence to antiemetic guidelines has been shown to have an impact on the percentage of patients experiencing all of the following outcomes except 1, no nausea, 2, no emesis without use of rescue medicines, 3, fewer visits to your primary care doctor, the specialist, or the ER, or to affect shorter hospitalization periods by following guidelines. Which one of these has been demonstrated?
Love stinks. Love stinks. Yeah, yeah. Love stinks.
So let's see what we have there. So we have a whole bunch of different answers. So the task is in front of me here. So, okay, we'll move on to the next one. And this is kind of unfair looking at a small number. In a recent observational study, the percentage of patients receiving HEC or MEC who also received guideline-consistent antiemetics was 13, 29, 38, or 53%. So maybe the best way, if you're not familiar with this study, is to say what you think would be the percentage that doctors follow. So obviously we have consensus, and there's no problem. It's kind of like a mask board meeting, so we can see that. So guidelines that are based on evidence, as we talked about earlier, therefore take efficacy, that's the evidence, and translate that into effectiveness, what really happens. And a slide I showed earlier says this has a big effect on quality of life short term during the chemotherapy period. The right-hand set of bars show that patients rate their quality of life in using a validated tool 3 days after the chemotherapy, the yellow bar, the same as they did immediately prior to chemotherapy, the green bar, if they don't have emesis. Now, on the other hand, if they did experience nausea or vomiting, they have a sudden 1/3 fall off by day 3 in their quality of life. This is miles above anything else that we use. Growth factors, all sorts of things. None of them have any effect that is similar to this. So it's really important to follow guidelines because of this quality of life, provided the guidelines really work. Now, we have different kinds of guidelines, which I talked about before: evidence-based, opinion-based, economically based, and most thoughtful groups that have looked into this say that the only ones that really make a lot of sense are evidence-based. Yet, we see a lot of consensus coming into this, or being what they agree upon. So opinion-based or consensus-based guidelines, well, how do we come about them if evidence makes sense? Well, they exist throughout the history of medicine. If you take our great-grandfather Hippocrates, he had this consensus statement: a young man does not take gout until he indulges in coition. It may actually be a true statement, but cause and effect is a little strange here. And it could have, if we were really trying to avoid gout, it could have quite an effect on the population. Now, this was said in 1839, about 10 years before anesthesia began to come in. The abolishment of pain in surgery is a chimera. It's absurd to go on seeking it. You really wouldn't want to have that on your CV at that time. And then we have a more recent statement, although 60 years old, made by somebody who worked at the National Cancer Institute at that time. If excessive smoking actually plays a role in the production of lung cancer, it seems to be a minor one. Okay, should we forgive this individual because it was 1954? Well, Ochsner and DeBakey published a wonderful paper in SGNO in 1939 that really outlined the terrific risk of that tobacco use has, and this person, you know, maybe he did a lot of other good things. His name is not so familiar to me at this point. Maybe it takes 60 years to live down a statement like that. That was the consensus. Dr. Ochsner was told for years to stop being on this tobacco binge of anti-tobacco. And so we do have to be careful about consensus. To that end, just last year, the prestigious Institute of Medicine put out a report saying, we are worried about this proliferation of guidelines. We need trustworthy guidelines, guidelines that we can all believe in. And this is really important. Maybe you have seen local guidelines, now we're talking about antiemetics, that differ quite a bit from international and evidence-based guidelines. These are to be rejected. I think that local guidelines, your own institution's guidelines, make sense as long as they do not vary from the international and the evidence-based guidelines. So if you want to say that there's a particular steroid that you prefer, okay, if there's evidence to show that methylprednisolone could be used instead of dexamethasone, that's fine, or some other aspect such as that. But to say you're not going to use triple therapy when all the international guidelines say that you should use the 3 agents is crazy. To say that you're not going to use triple therapy until a person has a problem violates guidelines. It makes no sense. If you have new evidence that should change the guidelines, please share that with the rest of us. And this is a lot of what the Institute of Medicine was saying. I would refer you to their website. It's pretty good reading. So evidence-based guidelines are where we need to be, but there are problems with evidence-based guidelines. First problem is it's really, the guidelines are best when they're evidence-based, but the problem is the level of evidence varies, and it's really difficult to have guidelines of high-quality evidence that cover every single setting. And so the problem, the dilemma then comes up with a group that wants to cover every setting, and so they've got a recommendation for everything, and they call it a guideline. That's a clinical pathway or a recommendation. It shouldn't be considered to be a guideline. I don't think it's too much of a semantic argument. The problem there is if any of us follow everything that they say and we find that something's not working, we won't believe the rest. The guideline groups have not been great in showing in easy ways where the guideline is based on really high quality evidence or where it's just what Joe, Bill, and Susan would do. And so we need to be a little more transparent in that. It's there, but it takes a lot of reading. So these are some of the problems with guidelines. It would be great to have evidence for all settings. And in fact, that's one of the things that's terrific about a guideline process like MASC has, because it shows where, it reveals where we don't have the most evidence. So in a study that I think Steve Grunberg was involved in the first bullet, they asked, so do you frequently or always follow major international guidelines? And the docs, 50 to 70% of the docs said, yep, you can trust me, I frequently or always follow them. And then in another study that followed almost 1,000 patients, only 29% of those patients actually were given guideline-compliant antiemetics. This is kind of surprising. Well, maybe not, because the same happens in guidelines outside of oncology as well. But then they followed those 991 patients in a study called the PEER study, which is just published by Matty Apro and other colleagues, and said, let's look at those folks who were treated according to guideline consistent, and then those who were treated inconsistent with guidelines. Was there a difference in the control rate of their emesis? Did it make a real difference? In other words, do guidelines really work? The guidelines are based on evidence. Let's take them, go back, and see what really happens. What a shocker. If we look overall, simply by following the guidelines, there was a significant difference in the control of emesis. Guidelines work. This was a surprise to all of us. And they did another analysis that was really interesting. They looked at resource utilization. So how many of those patients who were treated according to guideline or not according to guideline, what percentage needed to have an urgent care visit because of emetic problems? And lo and behold, there was a real and significant difference between those. It was lower for those on guideline and those not on guideline. Well, it's a relative 50% difference, which is great, but an absolute only 3% difference. Does that really matter? And if you look at the bottom, you can see that if you treated 100 patients per day, as many busy clinics do, this difference means 700 fewer emergency acute care visits per year in your practice, 700 fewer visits. So it really makes a difference. Now, it didn't make a big difference in hospitalization because these days, even not following guidelines but giving some of these agents makes enough of a difference to avoid hospitalization. What about nausea? We know we don't do as well in nausea, but following guidelines still had a significant, although lesser and not enough, of an impact on nausea. So it may be the best we can do. It still makes a difference. Nausea and vomiting are correlated, but nausea control lags behind. So to that end, we will have a nice discussion tomorrow afternoon about nausea and about incorporating it as primary endpoint, where we should be going, and different aspects of nausea, which Rebecca Clark will lead tomorrow afternoon. And so I think that should be a very interesting discussion. We've made this progress, but we still have a lagging behind in nausea, but nonetheless, following guidelines, again, was shown to be helpful and can help achieve these results. I want to, because Steve is so modest, Grunberg, I want to just show my favorite phase 2 that Steve has ever published. And there he looks at trying to make things as convenient as possible, which really makes things easy. What if you only gave all the antiemetics on one day? You gave Palo, the longer-acting 5-HT3 antagonist that has the superior results that Dr. Stricker talked about. You gave dexamethasone back up at the old dose of 20 milligrams, hoping that aprepitant will interfere with it and keep it around longer. And you gave all the aprepitant in the tri-pack together.